Imagine standing at the bedside of a patient whose brain is losing something like 2 million neurons every single minute. I mean, the clock is just ticking loudly.
Right. It's terrifying.
Yeah. You have a syringe of this incredible, powerful clot-busting drug in your hand. But if you push that drug under the wrong circumstances, you will literally cause a catastrophic, fatal hemorrhage right in front of your eyes.
Which is the absolute nightmare scenario for any clinician.
Exactly. That is the razor's edge of acute stroke management. So, welcome to Evidence at the Bedside Board Review Edition.
It's great to be here.
It is. The scenario we just described is exactly why we are focusing on this specific topic today. The board examiners, they know that in acute neurology, hesitation costs brain tissue.
Right.
But, recklessness costs lives.
Yeah, that underlying understanding is what really separates a passing score from a failing one on the ABIM. The examiners aren't just testing if you memorize the definitions, they are testing your clinical reasoning under intense pressure.
Absolutely. So before we get into the heavy clinical lifting, we want to invite you, our listener, to like this deep dive into the source material, subscribe to our show, and share this vital review session with your colleagues who are, deep in the trenches of board preparation.
It's a lifesaver for exam prep.
It really is. Our mission today is highly specific. We are dedicating this entire deep dive into stroke evaluation and management for the ABIM certification exam. We're going to unpack the pathophysiology behind the guidelines.
So you aren't just blindly memorizing algorithms.
Exactly. You're actually understanding the mechanics of the brain under duress.
And the entire foundation of stroke management is built on that concept you hinted at earlier, right? The whole time is brain thing. Because when an artery occludes, you have this central core of dead, infarcted tissue.
Right.
But surrounding that core is the ischemic penumbra.
The salvageable area.
Exactly. It's the zone of starving, electrically silent, but structurally intact brain tissue. And the exam forces you to prove that you understand exactly how to navigate the algorithms to save that penumbra without causing a secondary disaster.
So let's talk about how this actually looks on the exam.
Yeah.
We are not just going to read through a table of contents today. We are going to walk the clinical path exactly as you will on test day.
The locked room mystery.
Yes. The classic board scenario. You're sitting at the computer, and the vignette opens with a very specific, carefully constructed sentence. Picture a 70-year-old man who presents to the emergency department. He has a sudden onset right arm weakness and expressive aphasia. And then comes the absolute most important phrase in the entire schem.
Last known well 2 hours ago.
There it is.
That opening line is so dense with information. I mean, it gives you the demographics, which hints at underlying atherosclerotic risk factors. It gives you the sudden onset focal neurologic deficits, which is literally the World Health Organization's definition of a stroke. But you are absolutely right. The anchor point for everything that follows is that last known well time.
It's the absolute zero on your therapeutic clock. I always tell test takers to treat these question stems like a locked room mystery. The history and the physical exam are your only keys to unlocking the correct imaging pathway and the subsequent treatment cascade.
Yeah, you have to be a detective.
So when you see a question stem like that, you have to aggressively hunt for very specific clues. First, that time of onset. Is it within 3 hours? Is it within 4.5 hours? Or what if it's a wake-up stroke? Like the patient went to bed at 10 p.m. and woke up at 6 a.m. with a deficit.
Oh, the classic trap.
Yeah.
If it's a wake-up stroke, the last known well time is 10 p.m. the night before. It is not the time they woke up.
And that completely changes the game.
It immediately pushes them outside the standard window for intravenous thrombolysis, which fundamentally alters your entire management algorithm. You basically have to assume the stroke happened the minute they close their eyes.
Unless you have advanced perfusion imaging to tell you otherwise, but we'll get to that. That is exactly the kind of trap we are looking for. Second, after you establish the time, you must immediately scan the vignette for the vital signs, specifically the blood pressure readings.
They love to hide that.
They really do. The test makers will bury a blood pressure of like 1901-15 in a long paragraph of vitals just to see if you reflexively select the answer to give a thrombolytic.
Which would immediately kill the patient with hemorrhagic conversion.
Exactly.
It is a phenomenal test of discipline because blood pressure is the great gatekeeper here. It's the gatekeeper for both the ischemic thrombolysis pathway and for hemorrhagic stroke management, even though the goals for each are completely opposite.
Right. And beyond the vitals, you also need to scour their medication lists. The boards will test if you can distinguish between a patient taking a daily aspirin versus one on an active direct oral anticoagulant, because that completely dictates your bleeding risk.
And then there's the neuro exam details. They might not just hand you a neatly calculated NIH stroke scale score.
Yeah, that'll be too easy.
Right. They are going to describe the parameters, whether the patient is alert, if they have a partial heminopia, if they have a facial droop, arm drift, or severe expressive aphasia.
And sometimes they will throw in a subjective phrase like, the worst headache of my life, to instantly pivot your diagnostic reasoning.
Oh, yeah. When you see the worst headache of my life, your brain needs to immediately pivot away from an ischemic event and straight toward a subarachnoid hemorrhage.
Because the underlying mechanism there isn't a blocked pipe starving the tissue.
Exactly. It is a ruptured pipe dumping toxic high-pressure blood into the delicate subarachnoid space. It irritates the meninges and dramatically spikes the intracranial pressure.
This highlights the core challenge of the exam. You are driving down a clinical highway and you hit a major fork in the road. Is it an ischemic stroke, meaning a blocked pipe, or a hemorrhagic stroke, meaning a burst pipe?
Because the clinical presentation, the sudden onset focal weakness or speech loss, can look absolutely identical for both.
You cannot differentiate an ischemic stroke from a hemorrhagic stroke simply by looking at the patient or doing a physical exam.
Which leads us directly to the absolute mandatory first step in the evaluation of any suspected acute stroke. When you are sitting for the boards and they ask for the best initial test, the answer is invariably the non-contrast head CT.
Now, I want to push back on this for a second.
Sure.
Because this feels incredibly counterintuitive when you really think about the pathophysiology. We know that an MRI, specifically diffusion-weighted imaging, is vastly superior and far more sensitive for detecting acute infarction, right?
Oh, without a doubt.
An MRI can show cellular death and ischemic changes within minutes of symptom onset. Meanwhile, a non-contrast CT is often completely normal for the first 6 to 12 hours of an ischemic stroke. So if an MRI is scientifically more sensitive for the actual disease process, why do the boards heavily penalize you for picking MRI as the best initial test?
It's a brilliant question, and it really comes down to the fundamental logistics of emergency medicine and, well, the biological reality of that ischemic penumbra we talked about.
Okay, break that down for us.
So you are entirely correct that the non-contrast CT will likely be completely normal in an acute ischemic stroke. In fact, we expect it to be normal. The purpose of that initial scan is not to diagnose ischemia. The sole purpose is to rule out hemorrhage.
Ah, because blood shows up instantly on a CT scan.
Exactly. Acute extravasated blood is highly dense due to the iron and protein in the hemoglobin, so it appears bright white or hyperdense immediately on a CT scan. The CT is fast, it is widely available, and it requires no screening for metallic implants.
You just roll them right in.
You can roll a patient from the ambulance stretcher directly into the CT scanner in a matter of seconds. An MRI, on the other hand, takes agonizingly long to set up. You have to screen the patient for pacemakers or metal fragments, and the scan itself just takes much longer.
So while you are waiting for the MRI to show you a beautiful high-resolution picture of the infarct, millions of neurons in the penumbra are actively dying.
Precisely. Getting an MRI delays the single piece of information you need to proceed. Is there blood in the brain?
Wow, okay.
If the non-contrast CT shows no blood and the patient is within the time window, you can immediately initiate intravenous thrombolysis. An MRI is a secondary tool in this acute setting. It's obtained later to confirm the diagnosis, evaluate the vascular distribution, or establish secondary causes.
Okay, that makes perfect sense. The non-contrast CT is essentially a triage tool to clear the runway for clot-busting drugs.
Exactly.
So let's say we have our patient, they have an acute neurologic deficit, their CT scan shows zero hemorrhage, and we are now firmly in the acute ischemic stroke pathway. This is where the board examiners will rigorously test your knowledge of thrombolysis inclusion and exclusion criteria. We're talking about intravenous recombinant tissue plasminogen activator. So specifically alteplase given as a 1-hour infusion or increasingly tenecteplase given as a single rapid bolus.
And the mechanism of action here is critical to understand. These drugs are systemic serine proteases. They circulate through the entire body, they find the fibrin strands holding the blood clot together, and they activate plasminogen into plasmin.
Which then scissors those fibrin strands apart.
Yes, dissolving the clot. But because it is a systemic drug, it doesn't just target the clot in the brain, it dissolves clots everywhere.
Which is why the absolute sweet spot for administration is so narrow. The strict FDA-approved window is within 3 hours of symptom onset. National guidelines do endorse treatment between 3 and 4.5 hours for carefully selected patients, although that is technically off-label.
And this is exactly where the exam will try to lure you into a trap. They will hand you a patient who seems like the absolute perfect candidate. Right age, clear deficit within the 2-hour window. But they will hide a lethal contraindication in the stem. You must memorize the absolute exclusion criteria and, more importantly, understand why they exist.
Let's walk through them, because understanding the why makes it stick.
Exactly.
So, if the patient has had significant head trauma or a previous stroke in the past 3 months, you cannot give it.
Why? Because the brain tissue in those areas is still healing. The blood-brain barrier is compromised, and the local capillaries are incredibly fragile.
So if you give the drug,
If you flood the system with a powerful systemic thrombolytic, those healing vessels will rupture. You're turning a recovering injury into a massive, fatal intracerebral hemorrhage.
the same logic applies to recent intracranial or spinal surgery, right?
Yep, exactly the same logic.
And if there is any suspicion of a subarachnoid hemorrhage, even if the CT is negative, you cannot give it. Plus, a history of any previous intracranial hemorrhage ever in their entire life is generally an absolute contraindication.
Correct, because the structural integrity of their cerebral vasculature has already proven to be compromised in the past. It is simply too high a risk.
Now here's another one that test takers frequently miss. A structural gastrointestinal malignancy. Why does a tumor in the colon exclude you from getting a stroke drug for the brain?
It seems disconnected, right? But it's because gastrointestinal malignancies are highly vascularized and notoriously friable. They are essentially these abnormal tangles of blood vessels constantly oozing on a microscopic level.
Oh, I see.
Your body is constantly forming tiny, localized fibrin clots to keep that tumor from hemorrhaging. If you give systemic tenecteplase, it circulates down to the gut, dissolves all those protective microclots, and the patient will rapidly exsanguinate into their gastrointestinal tract.
That paints a very clear, terrifying picture.
It does.
You also have to scrutinize the laboratory values provided in the vignette. An active bleeding diathesis is an absolute no-go. Specifically, a platelet count of less than 100,000 completely disqualifies them.
And the medication history is equally, if not more, perilous. The boards love to test your knowledge of how different anticoagulants interact with the thrombolysis pathway.
Right.
If the patient received treatment dose heparin within the last 48 hours and has an elevated APTT, or if they are currently using a vitamin K antagonist like warfarin and their INR is greater than 1.7, thrombolysis is strictly contraindicated.
What about the newer agents? The direct oral anticoagulants or DOACs?
Yeah.
Because those are everywhere now.
The rules are very strict here, too. If the patient has taken a direct thrombin inhibitor like dabigatran or a direct factor Z inhibitor like apixaban or rivaroxaban within the last 48 hours, they are excluded from intravenous thrombolysis.
Are there any exceptions to that on the boards?
The only exception is if you have specific relevant laboratory tests, like a dilute thrombin time or specific anti-factor assays, proving that the drug has completely cleared their system. But on the boards, recent DOAC use is generally a hard stop.
Good to know. And finally, we have an exclusion criterion based on the imaging itself. Even if the CT scan shows no frank blood, if it demonstrates early ischemic changes that are massive, specifically a multilobar infarction involving more than 1/3 of the cerebral hemisphere, you cannot give the drug.
This brings us right back to pathophysiology.
Let's hear it.
If more than 1/3 of the hemisphere is already showing ischemic changes on a non-contrast CT, it means that tissue is not just starving, it is already dead. The cell membranes have ruptured, the capillaries are necrotic, and the tissue is literally turning to mush.
So if you dissolve the clot,
If you suddenly restore high-pressure arterial blood flow into a massive vascular bed of dead, leaking capillaries, the blood will simply extravasate into the brain tissue. This is called hemorrhagic transformation, and in a stroke of that size, it is almost uniformly fatal.
so we have established who gets the drug and who doesn't based on history and imaging. But there is one physiological parameter we haven't unpacked yet, and it is arguably the most highly tested trap in acute stroke management. Let's talk about the blood pressure threshold. What is the strict, unforgiving cutoff for giving a thrombolytic?
Before a thrombolytic agent can be safely administered, the blood pressure must be strictly lower than 110 millimeters of mercury.
185 over 100.
Yes. If it is equal to or greater than 105/110, that is an absolute exclusion criterion unless you can rapidly and successfully treat it.
Explain the physics behind that exact number. Why 185, 110?
Think of the ischemic area as a network of incredibly fragile, damaged pipes. The cells lining those capillaries are suffocating, losing their tight junctions, and becoming leaky.
Right.
If you push a clot-busting drug, you are opening the main floodgate. If the systemic pressure driving that blood, the water pressure, so to speak, is higher than 085/110, the sheer mechanical force and sheer stress will literally blow those damaged capillaries apart.
The incidence of symptomatic intracerebral hemorrhage just skyrockets once you cross that threshold.
It does.
So if a patient arrives an hour after their stroke, they're the perfect candidate, but their blood pressure is 1 for 5, 1 for 5. We don't just sit there and watch the clock run out, right? We intervene.
Exactly. You must aggressively but carefully lower it. The standard of care is to use a single bolus of intravenous labetalol, which is a combined alpha and beta blocker, or initiate an intravenous nicardipine or clofidipine infusion to smoothly bring the pressure down below that 15110 threshold.
And there is a specific medication class you must absolutely avoid here.
You explicitly avoid intravenous nitrovasodilators like nitroglycerin or sodium nitroprusside.
But why? I mean, they lower blood pressure, don't they?
They do lower it, but they achieve this by profoundly dilating venous capacitance vessels. In the brain, dilating the cerebral vasculature dramatically increases intracranial blood volume.
And the brain is enclosed in a rigid skull.
Precisely. If you increase the volume of blood inside that closed box, you exponentially increase intracranial pressure. That further compresses the very ischemic tissue you are trying to save.
Okay, so we use labetalol or nicardipine. We get the pressure to 180, 100, and we push the drug. Once the thrombolytic is running, the blood pressure must remain tightly controlled below 180, 105 for the next 24 hours to prevent that hemorrhagic conversion.
That's the golden rule post-hemolysis.
Now, here is where it gets really interesting and where we have to discuss a concept that feels completely backwards to every physician's training. We need to talk about permissive hypertension.
This is a massive paradigm shift for many test takers.
Let's set the scene. The boards give you a patient who had an ischemic stroke. They woke up with it, so they are well outside the thrombolysis window. They are not getting alteplase. They are resting in the emergency department, and their blood pressure is sitting at 2101 need 10.
High. Very high.
Every instinct in my body, as a physician trained to prevent cardiovascular damage, screams at me to lower that pressure. One of the answer choices will invariably be to administer intravenous labetalol. If I pick it, I fail the question.
You absolutely fail the question.
Walk me through the exact physics of what happens to the brain if I push that drug.
It feels incredibly counterintuitive, but to understand why you must sit on your hands, let's look at the actual hemodynamics of the ischemic penumbra. To use an analogy, imagine a neighborhood built high up on a massive hill.
Okay.
There is a single water main supplying the entire neighborhood, and someone has partially crushed that pipe. The houses at the very top of the hill are getting zero water. That is your dead, infarcted core.
Right.
But the houses on the slopes are getting just barely enough of a trickle to keep the grass alive, but not enough to actually live comfortably. That is your ischemic penumbra.
Okay, I see where this is going.
Now, the city's water department realizes the neighborhood is dying. Because they can't immediately uncrush the pipe, what do? They crank up the systemic water pressure at the main pump station to absolutely dangerous levels, trying desperately to force enough water through that narrowed, crushed pipe to push it up the hill to the starving houses.
That is the brain's auto-regulatory system taking over. The brain is commanding the systemic vasculature to clamp down and the heart to pump harder.
Precisely. The ischemic brain fundamentally alters the body's normal blood pressure set point to force collateral blood flow into the dying territory. Now imagine you, the physician, walk in. You see this massive spike in water pressure at the pump station. You panic, thinking the pumps are going to break, so you give a drug that forcefully dials the systemic pressure back down to normal.
The moment I lower the pressure, the water can no longer make it up the hill through the crushed pipe. The trickle stops entirely.
And the houses on the slope die.
Wow.
By lowering the systemic blood pressure, you catastrophically drop the cerebral perfusion pressure. You starve the ischemic penumbra, immediately converting a reversible ischemic deficit into permanent, irreversible infarction. You have functionally extended the size of the stroke.
That is a phenomenal analogy. So in this scenario, where the patient is not receiving a clot-busting drug, we practice permissive hypertension. What is the absolute ceiling? How high do we let it go before we intervene?
You only treat the blood pressure in this scenario if it hits 220, 120 millimeters of mercury or higher.
220 over 120. That is staggeringly high.
It is, but up to that point, you leave it alone for the first 24 to 48 hours to allow the brain to maximally perfuse itself. If it does exceed 220, 120, You cautiously lower it by only about 15% over the first day.
Are there any exceptions to this rule?
Hmm.
Because the boards love exceptions.
Yes, and they do love these. You are permitted to lower the blood pressure earlier only if the patient has a specific acute comorbid condition that demands immediate, life-saving blood pressure reduction.
Like what?
The big three are an acute aortic dissection, an acute myocardial infarction, or acute decompensated heart failure with pulmonary edema. In those specific scenarios, the immediate risk to the heart or the aorta outweighs the risk to the brain's penumbra, and you must lower the pressure. But absent those, hands off the labetalol.
That is a crucial board trap, beautifully explained. Do not drop the pressure unless you absolutely have to. Now, let's look beyond intravenous thrombolysis. The exam will heavily test the next major frontier in stroke management: endovascular therapy, specifically mechanical thrombectomy. We are no longer just relying on a drug to dissolve the clot. We are going in with a catheter to physically grab it and pull it out.
But this requires a specific type of stroke. Mechanical thrombectomy is only indicated for large vessel occlusions, or LVOs.
We are talking about the major highways of the brain. The terminal portion of the internal carotid artery, the main stem of the middle cerebral artery, which is the M1 segment, or the basilar artery supplying the brainstem.
Right. If a clot is lodged in a tiny distal cortical branch, you just can't get a catheter up there safely. But if the main highway is blocked, you can.
The time windows for endovascular therapy have really revolutionized neurology. Historically, we were limited to very short windows. Today, thanks to trials like DAWN and DEFUSE 3, mechanical thrombectomy can be considered up to 24 hours after symptom onset in carefully selected patients.
Which is incredible.
Walk us through the evaluation timeline for an LVO. Let's say a patient presents within the first 6 hours with a massive deficit, say global aphasia and dense hemiplegia. That suggests a large territory is at risk.
If they present under 6 hours with the suspected LVO, based on those severe cortical deficits or a high NIHSS score, the immediate next step after the non-contrast CT is to obtain emergent vascular imaging.
To see the blockage.
Exactly. This is typically a CT angiogram or an MR angiogram of the head and neck to visually confirm the occlusion in a large vessel.
But here is a critical point for the exam. Obtaining the CT angiogram should never, ever delay the administration of intravenous alteplase if the patient is within the 3 or 4.5-hour window and otherwise eligible.
Absolutely not. You do not wait to see the vascular imaging before starting the systemic lytic therapy. You start the drug infusion and you roll them immediately into the angiogram scanner while the drug is running.
Right. Now, what if the patient presents between 6 and 24 hours, or they woke up with a stroke?
This is where advanced imaging comes into play. We use CT perfusion imaging or diffusion-perfusion mismatch on MRI.
What exactly are we looking for to justify sending a neurointerventionalist into the brain that late?
We are looking for a mismatch between the core and the penumbra. The perfusion imaging uses software to map the blood flow. We want to see a very small central core of irreversibly dead tissue surrounded by a massive area of delayed perfusion.
Meaning a large volume of brain tissue that is still viable, but critically underperfused.
Exactly. If that mismatch exists, it means the brain has excellent collateral circulation keeping the tissue on life support. Going in to pull the clot out at hour 18 will actually save a huge amount of brain.
But if there's no mismatch?
If the core is already massive and the mismatch is small, the procedure carries all the risk of hemorrhage with none of the benefit and you abort.
Incredible. So we've covered the acute, hyperurgent management. Let's transition logically to the next phase. The patient survives the acute event. Now we need to figure out exactly why it happened so we can stop it from happening again.
The secondary prevention.
Yes. It is no longer enough on the boards to simply diagnose an ischemic stroke. The exam demands you figure out the exact plumbing problem. Are we dealing with a broken pump throwing debris, a rusted pipe bursting, or a clogged filter? Let's start with the broken pump. Cardioembolic strokes.
Cardioembolic strokes occur when a thrombus forms in the heart, breaks loose, and travels up the carotid arteries into the brain. Because these clots are often large and travel fast, they tend to lodge at major branch points, often involving the cortical surface or the cerebellum.
And they are notorious for causing sudden maximal deficits right at onset.
Correct.
And the undisputed champion, the most common cause of cardioembolic stroke by a wide margin, is
atrial fibrillation. The chaotic, ineffective quivering of the left atrium allows blood to stagnate in the left atrial appendage, form a clot, and eventually embolize.
The boards will present a patient whose vascular imaging of the head and neck is completely clean. No atherosclerosis, no narrowed vessels, but they have a massive cortical stroke. The problem isn't in the pipes, it's the pump.
Exactly. You start with a 12-lead ECG for everyone to look for atrial fibrillation.
But what if the ECG in the emergency room shows a perfectly normal sinus rhythm? Does that rule out atrial fibrillation?
Not at all. Many patients have paroxysmal atrial fibrillation. They go in and out of the abnormal rhythm. If the stroke pattern looks embolic, but the initial workup is negative, you diagnose an embolic stroke of undetermined source, or ESUS.
ESUS, right. And for these patients, the standard of care and the highly testable next best step is prolonged outpatient cardiac monitoring. This is done with a patch monitor for several weeks or an implantable loop recorder for months.
Because the data shows that prolonged monitoring will uncover silent paroxysmal atrial fibrillation in roughly a third of these ESUS patients.
And once you confirm atrial fibrillation, the board question will instantly pivot to ask you about the timing of anticoagulation. We know these patients need long-term blood thinners, specifically direct oral anticoagulants or DOACs to prevent the next stroke.
Right.
But you cannot just start a DOAC on day one while they're lying in the ICU with a massive fresh stroke. We have robust recent data from major trials, the START, timing, ELAN, and Optimus trials, that dictate the specific rules here. Without getting bogged down in the acronyms, what did these trials actually teach us?
They taught us that the blood-brain barrier within the infarcted tissue is heavily compromised. It is leaky and friable. The trials asked, when is it safe to fully anticoagulate the blood without causing the injured brain vessels to leak catastrophically?
And we used to wait a very long time, utilizing the 1-3-6-12-day rule.
We did. But the newer data has refined this. First off, emergent systemic anticoagulation with a heparin drip within the first 48 hours is universally condemned.
Universally.
Yes, it is not effective for preventing early recurrence, and it massively increases the risk of symptomatic hemorrhagic conversion.
So no heparin drips for acute stroke, even if they have a fib. When do we start the DOAC?
The timing depends entirely on the size and severity of the stroke. If the patient had a minor stroke, meaning the infarct size on imaging is less than 1.5 centimeters, or a moderate stroke confined to a superficial cortical branch, you can initiate the DOAC relatively early.
Early being when?
Usually between day 2 and day 4 after symptom onset.
But what if it is a severe stroke? What if it involves multiple branches or an entire arterial territory like the whole middle cerebral artery distribution?
Then you must wait. The tissue is too severely damaged, and the bleeding risk is astronomical. For severe strokes, you must delay DOAC initiation for 6 to 7 days, and sometimes up to 14 days, depending on follow-up imaging, to ensure no spontaneous bleeding has occurred.
And during that waiting period, you provide basic secondary prevention with daily aspirin.
Correct.
Let's move to the next subtype, large artery atherosclerosis. The mechanism here is completely different. This is the rusted pipe scenario. A cholesterol plaque builds up in the wall of a major artery, the fibrous cap ruptures, and platelets aggregate on the ulcerated surface, forming a clot.
And that clot either occludes the vessel in place or breaks off and embolizes downstream.
Exactly. Let's focus on the extracranial internal carotid artery, the ICA in the neck. The boards will give you a patient who just suffered a minor stroke, and a carotid duplex ultrasound shows greater than 70% atherosclerotic stenosis in the ipsilateral ICA. What is the standard of care here?
For symptomatic extracranial ICA stenosis greater than 70%, the patient has an incredibly high risk of suffering a massive, debilitating recurrent stroke within the next 2 weeks.
The plaque is highly unstable and actively throwing emboli.
Yes, so the next best step is not just medical management. It is early surgical revascularization.
Meaning we have to physically go in and clean the pipe out. The surgical options are a carotid endarterectomy, where a vascular surgeon opens the neck and peels the plaque out of the artery, or carotid artery stenting, where an interventionalist deploys a mesh tube to crush the plaque against the wall.
And the boards love to test which procedure is better and exactly when to do it.
Right, so what's the answer?
The European Society for Vascular Surgery guidelines, as well as major North American guidelines, generally favor carotid endarterectomy over stenting in the early period following a symptomatic event. The data shows that the optimal timing for the highest benefit and the lowest risk from a carotid endarterectomy is strictly between day 3 and day 14 after symptom onset.
Let's unpack the why behind those specific days. Why not operate on day 1? And why is it too late after day 14?
You generally avoid day 1 or 2 because the brain tissue has just suffered an ischemic insult. Reperfusion injury is a real threat if you suddenly restore full flow to highly vulnerable, freshly injured tissue.
Okay, that makes sense. By day 3, the brain has stabilized somewhat.
Right. And you intervene before day 14 because that is the window of maximum vulnerability. If you wait a month to operate, the unstable plaque has usually endothelialized and healed over, drastically reducing the stroke risk. At that point, the surgical risk might actually outweigh the natural history of the disease.
And why do we prefer endarterectomy over stenting in that critical first 2 weeks?
Stenting early on carries a higher risk of perioperative stroke. When you push a catheter and a stent up through a highly friable ulcerated plaque, the mechanical force often shears off microemboli.
The snowplow effect.
Exactly. You send debris up into the brain. Endarterectomy allows the surgeon to clamp the artery above and below the lesion, safely removing the plaque under direct vision without sending debris downstream.
I see.
Endarterectomy does carry a slightly higher risk of a perioperative myocardial infarction compared to stenting, but for preventing a recurrent stroke in the early phase, it is the superior choice.
It is also important to note that if the ultrasound shows complete 100% symptomatic occlusion of the ICA, revascularization is not indicated. The pipe is completely sealed off. There is no flow to carry an embolus, so you leave it alone. So that is disease in the neck. But here is a massive board pitfall. What if the stenosis is intracranial? What if the patient has greater than 70% symptomatic atherosclerosis inside the skull, like in the middle cerebral artery or the basilar artery? We just said we intervene for 70% stenosis. Do we send the interventionalist in to stent the brain?
You absolutely do not put a stent in the brain for atherosclerotic disease. This was definitively proven by the Sampras trial. Intracranial arteries are structurally completely different from the carotid artery in the neck.
How so?
The extracranial carotid is a thick-walled tube supported by dense neck muscle and fascia. Intracranial arteries are delicate, tortuous, thin-walled, and floating freely in cerebrospinal fluid.
So trying to navigate a stiff wire and deploy a rigid stent up there is a nightmare.
Exactly. The Sampras trial showed that stenting intracranial arteries caused significantly more strokes and deaths than it prevented. The procedure itself is incredibly dangerous due to the risk of vessel perforation or occlusion of tiny perforating branches.
So what is the right answer on the exam?
The correct answer on the exam for symptomatic intracranial stenosis is aggressive medical management. That means high-intensity statins, aggressive blood pressure control, and dual antiplatelet therapy, usually aspirin and clopidogrel, for a defined period of 90 days.
Perfect. Let's touch briefly on the small subcortical or lacunar infarcts. These are the classic pure motor or pure sensory syndromes. A patient comes in with profound weakness of their left face, arm, and leg, but their cortical functions are completely intact.
No aphasia, no visual field cuts, no neglect.
Right. That specific pattern points to a highly localized injury deep in the brain's wiring pathways. The imaging will reveal small punch-out infarcts, typically less than 1.5 centimeters in diameter, located in deep structures like the internal capsule, the thalamus, or the pons.
And the primary pathology here is not a ruptured plaque or a traveling clot. It is chronic architectural damage.
From what?
The primary risk factor is long-standing, poorly controlled hypertension. The high pressure forces plasma proteins into the walls of the tiny, single-branch penetrating arteries. This process, called lipohyalinosis, causes the vessel walls to thicken, hyalinize, and eventually occlude. It is a slow, chronic strangulation of the deep brain tissue.
Wow. Now let's talk about dual antiplatelet therapy, or DAPT. We touched on it for intracranial stenosis, but the boards heavily test the high-risk TIA and minor stroke pathway.
They love this topic.
A transient ischemic attack, or TIA, is defined as a transient episode of neurological dysfunction without evidence of acute infarction on imaging. The symptoms resolve, usually within an hour. It is easy to dismiss a TIA because the patient looks fine in the clinic. But a high-risk TIA is an absolute medical emergency. It is the herald symptom of an impending massive stroke. How do we stratify that risk?
We use the ABCD2 score to identify which patients are at the highest immediate risk. It is a simple tool you can calculate right at the bedside. It assigns points based on 5 variables. A is for age over 60, which scores 1 point.
Because older age implies a higher baseline burden of atherosclerosis.
Exactly. B is for blood pressure over 40/90 at the time of evaluation, scoring 1 point. High pressure implies a higher driving force for a vulnerable plaque to rupture.
Makes sense.
C is for clinical symptoms. If they had isolated speech impairment, that is 1 point. But if they had unilateral focal weakness, true motor deficits, that is highly concerning for a significant vascular territory and scores 2 points.
D stands for duration.
Yes. The longer the tissue was starved, the closer the vessel was to permanent occlusion. Symptoms lasting 10 to 59 minutes score 1 point. If the symptoms persisted for 60 minutes or longer before resolving, That scores 2 points. And the final D is for diabetes mellitus, which scores 1 point because of the chronic endothelial dysfunction associated with it.
If you calculate that ABCD2 score and it is 4 or greater, or if the patient has had an actual minor non-cardioembolic ischemic stroke with a low NIHS score of 5 or less, they fall into the high-risk category.
Yes, and that specific population requires aggressive, immediate intervention with short-term dual antiplatelet therapy. You initiate both aspirin and clopidogrel within 24 to 72 hours of symptom onset. The key here is short-term. The duration most commonly tested is 21 days or 90 days.
Why do we stop DATA-P after 90 days and drop back to monotherapy? If 2 drugs are good, aren't they better forever?
You'd think so, but post-hoc analyses of the major trials, like Chance and Point, revealed that the maximum benefit of preventing a recurrent stroke occurs in the first few weeks when the plaque is hottest.
Ah.
After 90 days, the atherosclerotic plaque has stabilized. Continuing 2 antiplatelet agents long-term no longer provides a statistically significant reduction in strike risk, but it dramatically increases the risk of severe, life-threatening gastrointestinal or intracranial hemorrhage. The risk curve essentially crosses the benefit curve.
You can also use aspirin combined with ticagrelor for 30 days based on the Tholish trial. This is particularly beneficial for patients who have CYP2C19 loss of function alleles.
Right, because clopidogrel is a prodrug.
Yeah. It requires the liver to metabolize it into its active form. If a patient lacks that specific liver enzyme, the clopidogrel does nothing. Ticagrelor is active right out of the bottle, bypassing that metabolic requirement. But the primary takeaway for the boards remains. A high-risk PIA or a minor stroke mandates short-term DAPT,
That covers the massive landscape of ischemic stroke.
which means we need to shift our focus entirely. We have spent all this time obsessing over how to clear blocked pipes and restore blood flow to a starving brain. But what happens when the problem isn't a blockage, but a catastrophic rupture?
It bleeds.
Welcome to the hemorrhagic strokes. These account for roughly 15% to 20% of all strokes, but carry a disproportionately massive short-term mortality rate. Hemorrhagic strokes are divided into 2 distinct anatomical catastrophes: intracerebral hemorrhage, or ICH, and subarachnoid hemorrhage, or SAH. Let's tackle ICH first.
Clinically, an ICH might present similarly to an ischemic stroke with focal deficits, but because blood acts as an irritating, space-occupying mass lesion, signs of elevated intracranial pressure are much more prominent.
So they look sicker.
Much sicker. The patient is much more likely to present with a severe headache, intractable vomiting, and a rapidly progressive decline in their level of consciousness. You roll them into the CT scanner, and the non-contrast head CT instantly reveals a bright white collection of blood inside the brain parenchyma.
But seeing the blood is only the first step. The board examiners want you to act as a forensic pathologist. You must differentiate the underlying cause of the bleed based almost entirely on its anatomical location. The brain geography tells the story.
Exactly. Let's look at the deep structures of the burn first. The basal ganglia, the thalamus, the pons, and the deep cerebellar nuclei. These areas are fed by tiny, fragile penetrating arteries branching directly off the massive high-pressure highways at a 90-degree angle.
If the CT shows a hemorrhage centered in these deep structures, the most common cause, overwhelmingly, is chronic hypertension.
We mentioned this earlier with lacunar strokes. It is the exact same pathophysiology. Chronic upward pressure causes lipohyalinosis. The vessel wall undergoes fibrinoid necrosis, weakening the smooth muscle.
The constant pounding pressure causes these weakened walls to balloon out, forming microscopic Charcot-Bouchard microaneurysms.
And eventually, one of these tiny aneurysms bursts under a sudden spike in pressure, and you get a deep hypertensive hemorrhage.
But what if the hemorrhage is not deep? What if the CT shows the blood is lobar, meaning it is situated out near the cortical surface, right under the skull, within the frontal, parietal, temporal, or occipital lobes? The differential diagnosis changes entirely.
Completely different.
If the exam gives you a patient older than 50, and they specifically note the patient has a normal blood pressure history, a lobar hemorrhage should make alarm bells ring in your head. You should immediately think of cerebral amyloid angiopathy, or CAA.
Cerebral amyloid angiopathy is a fascinating and devastating disease. It is characterized by the deposition of beta-amyloid protein, the exact same rogue protein associated with Alzheimer's disease, but instead of clumping in the brain tissue, it deposits directly into the tunica media and adventitia of the small to medium-sized arteries of the cortex and leptomeninges.
The amyloid basically replaces the strong, elastic, smooth muscle cells. It turns a flexible, rubbery blood vessel into something resembling an old, dried-out twig. they become incredibly fragile and prone to spontaneous rupture. The board exam might mention the Boston Criteria version 2.0 for diagnosing this condition non-invasively.
The Boston Criteria V2.0 utilizes clinical demographic data combined with highly sensitive MRI sequences, like gradient echo or susceptibility-weighted imaging, which are exceptionally good at highlighting microscopic iron deposits from old blood. To make a diagnosis of probable CAA, the patient must be 50 years of age or older. On the MRI, you need to see at least 2 strictly lobar hemorrhagic lesions.
These could be large macrohemorrhages, tiny asymptomatic cerebral microbleeds, or evidence of cortical superficial siderosis.
Let's define that term.
Yeah, cortical superficial siderosis sounds incredibly complex, but it simply means iron staining. Siderosis implies iron. When these superficial amyloid-laden vessels slowly ooze blood over years, the red blood cells break down, leaving a toxic ring of iron deposition right on the convoluted surface of the cerebral cortex. The MRI detects that iron ring.
Exactly. And crucially for the Boston criteria to diagnose CAA, there must be an absolute absence of any deep hemorrhagic lesions. If you see deep microbleeds in the basal ganglia, the underlying pathology is far more likely to be hypertensive small vessel disease, not CAA.
Alternatively, under the V2.0 criteria, you can have just one lobal hemorrhagic lesion if it is accompanied by a specific severe white matter feature, like severe perivascular spaces in the centrum semiovale.
And the centrum semiovale is just the massive semi-oval shaped area of white matter located deep under the cerebral cortex but above the deep gray matter.
Now, how do we manage an acute ICH? The blood pressure management here is the complete polar opposite of the permissive hypertension we allow for ischemic strokes.
In an ischemic stroke, we want high pressure to push blood past a blockage.
Yeah.
But in an acute intracerebral hemorrhage, there is no blockage. Yeah. There is a torn vessel actively pumping blood into the closed box of the skull.
Right.
The hematoma can rapidly expand over the first few hours, physically crushing the surrounding healthy brain tissue and causing lethal herniation. Our primary goal is to stop that hematoma from expanding.
So if a patient arrives with an ICH and their systolic blood pressure is sitting between 150 and 220, what is the target?
The goal is to aggressively but carefully lower the systolic blood pressure to a target between 130 and less than 140 millimeters of mercury. You want smooth, sustained control without wild fluctuations to improve functional outcomes. You manage this in a neuro-ICU setting using titratable intravenous drips like nicardipine or clofidipine.
But, as we mentioned earlier in the ischemic section, you must strictly avoid intravenous nitrovasodilators like nitroglycerin or nitroprusside,
because they cause profound cerebral venous vasodilation, increasing the volume of blood trapped in the skull and sending the intracranial pressure skyrocketing, which will cause the brainstem to herniate through the foramen magnum.
Now, here is a massive board question that tests your ability to think past basic logic. A patient comes in with a massive hypertensive ICH. Their medication list shows they take an 81 milligram aspirin daily at home. The intern looks at you and suggests, hey, they're actively bleeding, and their platelets are permanently inhibited by the aspirin. Let's give them a platelet transfusion to help form a clot and stop the bleeding. Sounds perfectly logical. What is the evidence at the bedside?
The evidence says absolutely unequivocally, do not do that.
Do not do it.
The definitive trial on this, the PAST-ECH trial, demonstrated that routine platelet transfusion in the setting of antiplatelet therapy-associated spontaneous ICH does not improve outcomes. In fact, it significantly worsens them. Mortality and poor functional outcomes were higher in the transfusion group.
Why? It seems so counterintuitive. Why would giving platelets to a bleeding patient kill them?
The precise mechanisms are still being debated, but the leading theory is that transfused platelets are not just inert structural plugs. They are highly biologically active cells. When you infuse them, they travel to the site of injury and immediately begin dumping vast quantities of pro-inflammatory cytokines into the perihematomal tissue.
Wow.
This massive inflammatory cascade dramatically exacerbates the cytotoxic edema and swelling around the bleed. Furthermore, the fresh platelets might cause microthrombosis in the tiny venules draining the area, causing venous congestion that worsens the bleeding.
So regardless of the exact mechanism, the clinical directive is clear. Platelet transfusion is explicitly not indicated.
Right.
What about managing the elevated intracranial pressure itself? We often see massive rings of cerebral edema surrounding the hematoma on the CT scan. The edema acts like a secondary mass lesion. In brain tumors, we routinely give massive doses of steroids to reduce swelling. Do we give glucocorticoids for ICH?
No. Glucocorticoids, like dexamethasone, are completely ineffective for reducing the specific type of cytotoxic and vasogenic edema associated with an acute intracerebral hemorrhage. They should not be used.
And they cause harm, right?
Yes. Not only do they fail to reduce the swelling, but they also bring a host of severe complications. Massive hyperglycemia, increased risk of systemic infection, and gastrointestinal bleeding.
If you need to temporarily reduce dangerously high intracranial pressure to prevent herniation while awaiting neurosurgery, what do you use?
You use osmotherapy. You administer boluses of hypertonic saline or mannitol. These agents pull water directly out of the healthy brain tissue via the osmotic gradient, temporarily shrinking the overall volume of the brain and buying you precious time.
Let's move to the other distinct type of hemorrhagic stroke, the subarachnoid hemorrhage, or SAH. This is bleeding into the subarachnoid space, where the cerebrospinal fluid flows. The classic clinical presentation is unforgettable. It is the thunderclap headache, reaching absolute maximal intensity within seconds of onset, almost invariably described by the patient as the single worst headache of their entire life.
The most common cause of a spontaneous SAH is the rupture of a saccular aneurysm, often called a berry aneurysm, typically located at the branch points of the circle of Willis at the base of the brain. When these burst, arterial blood at systemic pressure explodes into the subarachnoid space.
You start the workup with a non-contrast CT, and timing is critical here.
If the CT is performed within the first 6 hours of the onset of the thunderclap headache, modern high-resolution scanners have near 100% sensitivity for detecting subarachnoid blood. A completely normal CT within 6 hours makes an SAH exceptionally unlikely.
But if the symptoms have been present for more than 6 hours or days, the sensitivity of the CT scan drops precipitously as the blood begins to wash away in the CSF. If the CT is entirely normal, but your clinical suspicion remains high because the story is perfectly classic for a thunderclap headache, what is the mandatory next step?
You are required to perform a lumbar puncture. You are evaluating the cerebrospinal fluid directly. You are looking for the presence of red blood cells that do not clear between tube 1 and tube 4, and most importantly, you are looking for xanthochromia.
Let's define xanthochromia.
Xanthochromia is the yellowish discoloration of the CSF. When red blood cells sit in the spinal fluid, they eventually lyse and break down. The hemoglobin is metabolized into oxyhemoglobin and eventually bilirubin, which turns the fluid yellow.
And this enzymatic breakdown process takes time.
It typically takes about 6 to 12 hours after the hemorrhage for xanthochromia to develop. That is why the lumbar puncture is the definitive test if the patient presents late.
To diagnose the source of the bleeding, the aneurysm itself, we typically start with a CT angiogram. But the absolute gold standard, and potentially the therapeutic intervention, is catheter-based digital subtraction angiography. Now, when treating SAH in the intensive care unit, there are two distinct prognostic scales the boards love to test: the Hunt-Hess scale and the modified Fisher scale. How do they differ?
They measure entirely different things. The Hunt-Hess scale predicts overall mortality based on the patient's clinical presentation at the door. It grades the severity of the neurological deficit.
From 1 to 5.
Yes, it ranges from grade 1, which is a patient who is completely alert with just a mild headache, all the way to grade 5, which is a patient in a deep coma with decerebrate posturing. A higher Hunt-Hess grade correlates with a grim prognosis.
And the modified Fisher?
The modified Fisher scale, on the other hand, is an imaging scale. It predicts the specific risk of the patient developing cerebral vasospasm later in the course. It looks exclusively at the initial CT scan and grades the thickness of the subarachnoid clot and the presence of bilateral intratracheal hemorrhage. More blood equals higher vasospasm risk.
Managing an SAH is truly a dual-front war. You have to fight two distinct life-threatening complications that occur on very different timelines. In the first 48 hours after the headache, what is the absolute greatest risk to the patient?
The greatest risk is rebleeding of the unsecured aneurysm. The initial clot that plugged the hole in the aneurysm is incredibly fragile. If it pops off, the aneurysm re-ruptures. The mortality rate of a rebleed approaches 70%.
So your primary goal is to secure the aneurysm as early as possible.
Typically within that 48-hour window. This is achieved either by an open neurosurgical craniotomy to place a titanium clip across the neck of the aneurysm, or by endovascular coiling, where an interventionalist packs the aneurysm dome with platinum coils to induce permanent thrombosis.
And during that perilous 48-hour waiting period before the aneurysm is secured, you must maintain incredibly strict blood pressure control. You keep the systolic blood pressure aggressively below 160 millimeters of mercury to prevent the mechanical force from blowing that fragile clot off the dome.
Exactly. But once the aneurysm is successfully clipped or coiled, you have won the first battle, but you have not won the war. A new, insidious, and uniquely terrifying threat emerges several days later.
This is a quintessential board pearl. We are talking about cerebral vasospasm.
Here is the pathophysiology. The subarachnoid space is filled with thousands of cubic centimeters of toxic, degrading blood products. As the red blood cells break down, they release massive amounts of oxyhemoglobin.
Right?
Oxyhemoglobin acts as a profound scavenger of nitric oxide, which is the brain's primary vasodilator. The depletion of nitric oxide, combined with the release of endothelin-1, causes the large intracranial arteries bathed in this blood to undergo intense, sustained, pathological, smooth muscle constriction. They literally clamp shut.
This severe narrowing restricts blood flow to the brain tissue, leading to delayed cerebral ischemia. The patient might have been talking to you perfectly on day 4, but suddenly on day 6, they become confused, lethargic, or develop a dense hemiparesis. The timing is highly specific.
The risk for vasospasm rarely occurs before day 4. It typically starts around day 5, peaks between days 7 and 10, and can persist up to day 21. You monitor for it continuously in the ICU using daily transcranial Doppler ultrasounds.
Looking for velocity changes.
Yes. The ultrasound technician measures the velocity of the blood flowing through the middle cerebral artery. As the artery narrows from spasm, the physics of fluid dynamics dictates that the velocity of the blood must massively accelerate to get through the stricture. A rising velocity curve on the Doppler means vasospasm is imminent.
And to prevent it, we have a highly specific, mandatory pharmacologic intervention.
Prophylactic nimodipine. It is a highly lipophilic dihydropyridine calcium channel blocker that readily crosses the blood-brain barrier. It prevents the influx of calcium into the smooth muscle cells of those specific cerebral arteries, minimizing the spasm.
And it's proven to work.
It has been proven in randomized trials to significantly improve neurological outcomes by reducing the incidence of delayed cerebral ischemia. You must start nimodipine as early as possible after the hemorrhage and continue it faithfully for a full 21 days to cover the entire window of risk.
That brings us to concept 5, in-hospital medical complications. These are the mundane, non-neurological issues that plague stroke units and frequently kill patients who survive the initial brain injury. Deep vein thrombosis and massive pulmonary embolisms are leading causes of mortality in immobilized stroke patients. The boards will test exactly when you are allowed to start pharmacologic DVT prophylaxis.
The timing depends entirely on the mechanism of the stroke. For a standard acute ischemic stroke, you start subcutaneous heparin or enoxaparin immediately upon admission. The only exception is if the patient received intravenous thrombolysis. Because you just flooded their system with alteplase, you must wait a mandatory 24 hours and obtain a repeat non-contrast head CT to definitively ensure there is no hemorrhagic conversion before you introduce a prophylactic blood thinner.
What if the patient came in with a hemorrhagic stroke? They're actively bleeding into their brain. Giving them heparin feels so wrong.
It does feel wrong, but a massive PE will kill them just as quickly as the ICH. The guidelines state you wait 24 to 48 hours after the initial bleed. You then obtain a repeat CT scan. If the scan proves that the intracerebral hematoma is completely stable and has stopped expanding, you can and should initiate standard subcutaneous chemical prophylaxis.
For an SAH, you wait until after the aneurysm is surgically secured. Let's discuss 2 more long-term complications the boards routinely test: depression and fatigue. Post-stroke depression is incredibly common, affecting up to 1/3 of patients. It is one of the leading modifiable risk factors for long-term disability and poor rehabilitation outcomes. You must actively screen for it, and if it develops, you treat it aggressively with psychotherapy or pharmacotherapy. But the boards will try to bait you into prescribing something unnecessarily.
The trap is prescribing selective serotonin reuptake inhibitors, or SSRIs, prophylactically to stroke patients who have zero signs of depression, simply under the mistaken belief that the drug will magically enhance motor recovery or neuroplasticity.
Which people used to think.
They did, but the most recent rigorous clinical data definitively does not support this practice. Not only do prophylactic SSRIs fail to improve functional recovery, but they actively increase the patient's risk of adverse events, specifically severe bone fractures from falls and gastrointestinal bleeding. Do not prescribe them unless the patient is clinically depressed.
And regarding fatigue, it is a pervasive complaint after a stroke. But it is strongly associated with the development of post-stroke sleep-disordered breathing, specifically obstructive sleep apnea. If a stroke patient complains of severe daytime fatigue, the intern will suggest handing them the standard Epworth Sleepiness Scale screening questionnaire.
That is the wrong move on the boards. Standard sleep apnea screening questionnaires have been shown to have very poor sensitivity and specificity in the post-stroke population. The correct diagnostic step on the boards is to refer them directly for a formal polysomnography, a full overnight sleep study, to secure the diagnosis.
Excellent. We have laid out all the puzzle pieces. Now it is time to see how the board examiners arrange them. Welcome to segment 3, board-style clinical vignettes. We're going to walk through 7 interactive scenarios, simulating the exact rhythm of the exam. As you listen, I want you to actively lock in your diagnosis and your next step before Dr. Dricken dissects the answer.
Ready when you are?
Let's begin with Vignette 1, the blood pressure trap. A 65-year-old woman is brought to the emergency department by EMS with sudden onset right-sided weakness and a severe expressive aphasia. Her husband states that they were eating breakfast when she suddenly dropped her fork. He states she was last known well exactly 2 hours ago. Her vital signs are notable for a heart rate of 88 and a blood pressure of 115 millimeters of mercury. A non-contrast head CT is performed immediately and shows no evidence of hemorrhage. So let's break down the presentation.
Well, we have an acute, sudden onset focal neurologic deficit localizing to the left hemisphere. The last known well time is clearly witnessed and is exactly 2 hours ago. This places her squarely within the 3-hour golden window for intravenous thrombolysis.
Yeah.
The CT shows no blood, definitively classifying this as an acute ischemic stroke. But we hit a major roadblock. Her blood pressure is routine 5115.
So the correct diagnosis is an acute ischemic stroke within the thrombolysis window, accompanied by prohibitive hypertension. What is the highly testable next best step in management?
The next best step is to immediately administer a titratable intravenous antihypertensive. You order 5-E-Labatol or an acardipine infusion to acutely and smoothly lower her blood pressure to strictly below 180/50/110 millimeters of mercury. Only after you have confirmed that the blood pressure is sustained below that critical threshold can you safely administer the Alplaz or Tenecteplase.
Let's talk about why the alternatives on the exam are completely wrong. One choice will undoubtedly be to administer the alteplase immediately because time is brain.
If you push a thrombolytic while her blood pressure is 1/119, you have knowingly violated an absolute contraindication. The sheer stress of that high pressure pounding against the ischemic necrotic capillaries will blow them out. You dramatically increase the risk of a fatal symptomatic intracerebral hemorrhage.
Another choice will be to admit the patient to the neuro ICU and simply monitor the blood pressure for an hour to see if it drops spontaneously.
Unacceptable clinical care. You are actively wasting precious, salvageable brain tissue. Time is brain means you do not sit and wait. You have a narrow window of opportunity, and you must aggressively intervene pharmacologically to make the patient a candidate for reperfusion therapy.
Right. Let's move to Vignette 2, the minor stroke high-risk TIA. A 72-year-old man with a long-standing history of type 2 diabetes mellitus presents to the outpatient clinic. He reports that yesterday afternoon he experienced sudden left arm weakness and numbness that lasted for exactly 45 minutes before completely resolving on its own. He did not seek medical care at the time. His current comprehensive neurologic examination in the clinic is entirely normal. His blood pressure today is 145/92. A carotid duplex ultrasound shows no significant stenosis, and an ECG shows normal sinus rhythm. What are we looking at here?
The clinical symptoms, focal arm weakness, completely resolved within an hour without any residual deficit. So clinically, this was a transient ischemic attack. But we cannot just send him home. We must risk stratify him using the ABCD2 score to determine the immediate urgency of our intervention. Let's calculate it. He is 72, which is over 60, so that is 1 point for age. His clinic blood pressure is 145/92, which is over the 1490/90 threshold, giving him 1 point for blood pressure. His clinical symptom was focal weakness, which is a major motor deficit, scoring 2 points. The duration of the episode was 45 minutes, which falls perfectly in the 10 to 59-minute range, earning 1 point. And he has a history of diabetes, which is another 1 point. His total ABCD2 score is 6 out of 7.
A score of 4 or greater firmly categorizes this as a high-risk TIA, so the correct diagnosis is high-risk PIA. What is the next best step to prevent the massive stroke that is likely coming his way?
The next best step is to immediately initiate short-term dual antiplatelet therapy. You write a prescription for both aspirin and clopidogrel and instruct him to start them today, well within the 72-hour window of his symptom onset. You plan to continue this DAPT regimen for 21 to 90 days before dropping back to aspirin monotherapy.
Why are the alternatives wrong? A very common distractor will be to prescribe high-dose aspirin monotherapy.
Aspirin monotherapy is simply less effective at preventing a recurrent stroke during this specific, highly volatile early window. The major trials clearly demonstrated superiority for the combination of two antiplatelets in this specific population.
Another distractor will be to admit him to the hospital and start a continuous intravenous heparin drip.
Systemic anticoagulation with heparin is almost never the answer for a non-cardioembolic TIA. The mechanism is a ruptured atherosclerotic plaque, which is platelet-driven, not a stagnant red clot from the heart. Heparin provides no additional benefit but massively increases the risk of systemic bleeding.
All right, Vignette 3. Symptomatic extracranial stenosis. A 68-year-old woman is being evaluated on the hospital ward. 5 days ago, she suffered a minor non-disabling ischemic stroke localized to her left cerebral hemisphere. Her recovery has been excellent, and she is ambulating well. A CT angiogram of her head and neck, performed as part of her stroke workup, reveals an 85% atherosclerotic stenosis in the left proximal extracranial internal carotid artery.
We must connect the anatomy to the clinical presentation. We have a recent non-disabling ischemic stroke in the left hemisphere, which is the exact downstream vascular territory of the severe greater than 70% atherosclerotic plaque sitting in her left neck.
The correct diagnosis is symptomatic large artery atherosclerosis. What is the highly testable next best step?
The next best step is to consult vascular surgery to schedule a carotid endarterectomy, or CEA. The clinical data dictates that the optimal window for surgical intervention, where the benefit of preventing recurrence far outweighs the surgical risk, is strictly between day 3 and day 14 following the onset of symptoms. Since she is currently on day 5, she is sitting in the absolute perfect window for surgery.
What about carotid artery stenting? The interventional cardiologist might want to do it, and it will definitely be an answer choice.
Per the European Society for Vascular Surgery guidelines, a carotid endarterectomy is explicitly recommended over stenting for patients undergoing early revascularization within that first 14-day window. Stenting a highly friable, freshly ruptured plaque in the early period carries a significantly higher perioperative stroke risk because the catheter pushes debris upstream.
And what if an answer choice suggests simply discharging her on a high-intensity statin and antiplatelet therapy and adopting a wait-and-see approach?
Medical management alone is grossly insufficient here. A symptomatic stenosis of greater than 70% carries an incredibly high double-digit risk of a massive recurrent stroke within the first 2 weeks. A wait-and-see approach represents a failure to intervene during the period of maximal biological risk.
Let's shift gears entirely to Vignette 4. Intracerebral hemorrhage on antiplatelets. A 75-year-old man presents to the emergency department complaining of a sudden, severe headache, intractable nausea, and profound weakness. On exam, he has a dense left-sided hemiplegia. His wife notes he has a history of coronary artery disease and takes an 81 milligram aspirin tablet every single day. His blood pressure on arrival is 70/95. A non-contrast head CT scan reveals a large acute hemorrhage centered deep in the right basal ganglia.
We have an acute intracerebral hemorrhage. The anatomical location is the key to the diagnosis. The hematoma is in the basal ganglia, which is a classic deep brain structure. This strongly, almost exclusively, points to the rupture of tiny perforating arteries damaged by long-standing hypertensive lipohyalosis.
The correct diagnosis is a hypertensive intracerebral hemorrhage. What is the next best step?
The immediate next best step is to aggressively lower his blood pressure. You initiate a titratable intravenous antihypertensive drip to bring his systolic blood pressure down to a tight target range between 130 and less than 140 millimeters of mercury. This minimizes the mechanical force driving the bleeding and prevents the hematoma from expanding and crushing the brainstem.
And the boards will offer you a platelet transfusion as a very tempting distractor, reasoning that since he takes daily aspirin, his platelets are irreversibly inhibited and he needs fresh ones to form a clot.
This is a PTCH trial trap we discussed. You must explicitly reject the platelet transfusion. The evidence demonstrates that transfusing platelets for an antiplatelet-associated spontaneous ICH does not improve outcomes and actively worsens mortality and functional independence due to complex inflammatory cascades.
Another wrong answer will be to administer intravenous dexamethasone to reduce the massive swelling surrounding the deep bleed.
Completely incorrect. Glucocorticoids are physiologically ineffective for reducing the specific edema generated by an ICH. They offer no benefit and bring substantial harm.
Vignette 5. Subarachnoid hemorrhage complication. A 55-year-old woman is currently recovering in the neuro ICU. 6 days ago, she arrived with a thunderclap headache and was diagnosed with a ruptured anterior communicating artery aneurysm. The aneurysm was successfully secured with endovascular platinum coiling on hospital day 1. She has been stable and conversant, but today, on day 6, the nurse calls you to the room because she has suddenly become confused, lethargic, and has developed a new, profound right leg weakness.
The timeline is the diagnostic linchpin here. It is hospital day 6 following an aneurysmal subarachnoid hemorrhage. The aneurysm itself was definitively secured on day 1, so the probability of a catastrophic rebleed is exceptionally low. Those typically happen in the first 48 hours. Day 6 lands perfectly in the classic temporal window for the toxic breakdown products of the subarachnoid blood to induce intense, sustained constriction of the surrounding cerebral arteries.
The correct diagnosis is delayed cerebral ischemia secondary to cerebral vasospasm. What is the next best step to confirm this?
You need to visualize the spasm. The next best step is to order an immediate transcranial Doppler ultrasound to measure the velocity of blood flow in her large intracranial arteries. If the velocities have skyrocketed, you have your diagnosis. Alternatively, you could order a CT angiogram combined with CT perfusion imaging to see the narrowed vessels and the resulting areas of poor blood flow. And of course, you must verify that she has been receiving her prophylactic oral nimodipine continuously since admission.
Why is an answer choice suggesting aneurysm rebleeding incorrect?
Because the aneurysm was successfully filled with platinum coils and the timeline is wrong. By day 6, vasospasm is overwhelmingly the most statistically likely culprit for an acute, unexplained neurological deterioration.
Okay, Vignette 6, cardioembolic stroke and anticoagulation timing. A 78-year-old man is brought in by ambulance after being found down in his apartment. He is aphasic with a dense right hemiplegia. A CT scan confirms a massive, severe ischemic stroke involving the entire territory of the left middle cerebral artery. His NIHSS score is 22, indicating profound impairment. Because his last known well time was 18 hours ago, he is well outside the window for any thrombolysis or mechanical thrombectomy. In the emergency department, his 12-lead ECG reveals a new onset, rapid atrial fibrillation.
This is the devastating reality of a massive cardioembolic ischemic stroke. The source is clearly the atrial fibrillation, but because the infarct involves the entire MCA territory, the absolute volume of dead necrotic brain tissue is vast. The blood-brain barrier across an entire hemisphere is essentially destroyed.
The correct diagnosis is a severe cardioembolic ischemic stroke. The board question will focus on secondary prevention. What is the next best step regarding his anticoagulation?
For a severe stroke of this magnitude, the next best step is to start simple daily aspirin acutely for basic secondary prevention, but you must deliberately delay the initiation of therapeutic anticoagulation, like a DOAC, for a minimum of 6 to 7 days and potentially longer.
And the distractors will tempt the test taker to start an apixaban pill immediately or start him on a continuous heparin drip because he has atrial fibrillation and he just threw a massive clot. We must stop the next one.
Giving into that temptation would be a fatal error. The dead brain tissue is practically liquefied. The capillaries are shredded. If you introduce full systemic anticoagulation immediately, the blood will inevitably leak through those shredded capillaries, resulting in a massive hemorrhagic conversion that will expand, herniate the brainstem, and kill him. You must wait the 6 to 7 days for the infarcted tissue to biologically stabilize and begin forming a glial scar before introducing blood thinners.
Our final scenario. Vignette 7, the lobar hemorrhage. An 82-year-old woman is brought to the emergency department by her daughter after a sudden onset of confusion and severe right-sided sensory loss. The daughter explicitly notes that her mother has always had low blood pressure and has never taken antihypertensive medications. Her blood pressure on arrival is 120/80. A non-contrast head CT scan reveals an acute hemorrhage located superficially in the left parietal lobe. A follow-up susceptibility-weighted MRI reveals the acute hematoma, along with dozens of tiny, strictly lobar microbleeds scattered across the cortex with absolutely no deep hemorrhagic lesions in the basal ganglia.
We have a classic presentation. She is elderly, over 50, and normotensive. The acute hemorrhage is strictly lobar, meaning it is located near the cortical surface, not deep in the brain's core. Furthermore, the highly sensitive MRI confirms a history of multiple prior asymptomatic microbleeds that are also strictly confined to the lobar regions. This exact constellation of findings perfectly fulfills the Boston criteria V2.0.
The correct diagnosis is probable cerebral amyloid angiopathy, or CAA. What is the next best step regarding her long-term clinical management?
The single most critical management directive for a patient with CAA is the strict, lifelong avoidance of systemic anticoagulation. Patients with CAA possess incredibly brittle, amyloid-laden blood vessels and carry an exceptionally high annual risk, sometimes exceeding 10% of suffering a recurrent spontaneous intracerebral hemorrhage.
So if she develops atrial fibrillation a year from now, putting her on warfarin or a DOAC is incredibly dangerous.
It is essentially a death sentence. If she develops a compelling indication for anticoagulation, you must seek alternative non-pharmacologic strategies like a percutaneous left atrial appendage closure device because blood thinners will inevitably cause catastrophic bleeding from those diseased cortical vessels.
And the primary distractor on the exam will be assuming this is just a standard hypertensive hemorrhage.
Which demonstrates a failure to synthesize the data. Assuming it is hypertensive completely ignores the patient's explicitly normotensive history and, most importantly, violates the neuroanatomy. Hypertensive bleeds consistently rupture the deep penetrating arteries of the thalamus, basal ganglia, and pons. CAA specifically targets the superficial cortical and leptomeningeal vessels. Location is everything.
Excellent. That wraps up our deep dive into the clinical vignettes. Now we move into segment 4. High-yield testable points. We're going to rapid fire through the most testable, isolated facts that you simply must commit to memory. I will set up the prompt, and our expert will provide the necessary clinical context. Let's start. Here's something the boards love to ask. What is the single most common cause of a cardioembolic stroke?
Atrial fibrillation. It is the silent killer. The boards want you to actively hunt for it. If the initial ECG and telemetry are completely negative, but the stroke pattern is undeniably embolic, for instance, if the MRI shows multiple small infarcts scattered across different vascular territories, or a classic wedge-shaped cortical infarct, you must diagnose an embolic stroke of undetermined source, or ESUS. The standard of care is to order prolonged outpatient cardiac monitoring with a patch or an implantable loop recorder, because a massive percentage of these patients are harboring silent, paroxysmal atrial fibrillation that simply evaded the initial 24-hour telemetry.
Next. What is the absolute best initial diagnostic test for any patient with a suspected acute stroke?
The non-contrast head CT. We explored the physics of this extensively, but always remember the why. You are not ordering it to diagnose the ischemia. It will likely be completely normal. You are ordering it exclusively to rule out a massive hemorrhage so that you can safely evaluate the patient's eligibility for clot-busting thrombolytics.
What is the absolute gold standard diagnostic test for mapping subarachnoid hemorrhage aneurysms?
Catheter-based digital subtraction angiography, or DSA. While a non-invasive CT angiogram is a fantastic initial screening tool, DSA provides the definitive, dynamic, high-resolution mapping of the intricate vascular anatomy. The neurosurgeon needs this map for precise treatment planning. More importantly, DSA offers an immediate, real-time therapeutic avenue. The interventionalist can thread platinum coils directly into the aneurysm dome during the exact same diagnostic procedure.
What is the mandatory first-line therapy for vasospasm prophylaxis in a patient with a subarachnoid hemorrhage?
Oral nimodipine. It is a highly specific lipophilic calcium channel blocker that crosses the blood-brain barrier to prevent calcium influx into the smooth muscle of cerebral arteries. It is the only drug proven to improve long-term neurologic outcomes by preventing delayed cerebral ischemia. You must initiate it early and continue it religiously for a full 21 days, covering the peak risk window of days 5 through 14.
Now, let's pivot to contraindicated medications. The board examiners love to test your knowledge of what not to do, because doing the wrong thing in stroke management is often fatal. We already covered the absolute prohibition against giving platelet transfusions and antiplatelet-associated ICH. But what about prescribing prasugrel to a patient with a previous stroke?
Prasugrel is a remarkably potent antiplatelet agent frequently used by cardiologists after placing cardiac stents. However, it carries a severe black box warning and is absolutely definitively contraindicated in any patient with a history of a TIA or an ischemic stroke. The trials showed that its extreme potency significantly increases the risk of a fatal spontaneous intracranial hemorrhage in this specific population. You must identify the stroke history and choose a safer alternative, like clopidogrel or ticagrelor.
What about administering glucocorticoids to reduce cerebral edema in an ICH or an SAH?
Strongly contraindicated. They are physiologically incapable of reducing the specific cytotoxic edema generated by these bleeds. They provide zero clinical benefit and are strongly associated with worse neurological outcomes, severe hyperglycemia, and an increased rate of systemic infections.
And using intravenous nitrates for rapid blood pressure control in an acute expanding ICH.
A catastrophic error. Intravenous nitroglycerin and nitroprusside are profound cerebral vasodilators. In a patient who already has a massive expanding hematoma and dangerously elevated intracranial pressure, dilating the cerebral venous beds will massively increase the total intracranial blood volume, spiking the ICP even higher and potentially causing the brainstem to herniate downward.
Let's review mortality predictors in intracerebral hemorrhage. If you were asked to calculate the widely used ICH score, what specific variables are you looking for?
The ICH score is heavily tested because it is remarkably predictive. It comprises 5 distinct components: the patient's initial Glasgow Coma Scale score, a lower score is worse; their age, over 80 is worse; the absolute volume of the hematoma on the CT scan, greater than 30 cubic centimeters, is worse; the presence of blood leaking into the ventricular system, intraventricular hemorrhage, and whether the origin of the bleed is infratentorial, meaning down in the tight confines of the cerebellum or brainstem. Higher cumulative scores correlate with devastating mortality rates, often exceeding 95%.
And finally, let's briefly summarize the primary risk scoring tools you absolutely must memorize.
For TIA risk stratification, it is the ABCD2 score, which dictates your decision to initiate immediate dual antiplatelet therapy to prevent an impending stroke. For a subarachnoid hemorrhage, you must separate the clinical from the radiological. You need the Hunt-Hess scale, which grades the physical clinical presentation from a mild headache to a deep coma to predict overall mortality. And you need the modified Fisher scale, which grades the thickness and anatomical distribution of blood on the initial CT scan to specifically predict the risk of developing delayed cerebral vasospasm.
Fantastic review. Let's move into our final teaching segment, clinical pearls and pitfalls. This is where brilliant test takers fall into carefully laid traps because broad textbook guidelines sometimes clash with specific, nuanced board constraints. Let's look at pitfall 1. Over-evaluating the older adult. You are presented with an 80-year-old patient who suffers a massive ischemic stroke. The 24-hour telemetry shows normal sinus rhythm with no atrial fibrillation. The board question asks for the next best diagnostic test to find the source, and one of the highly tempting options is a transesophageal echocardiogram, TE. Why is selecting TE a trap?
A T is an incredibly powerful test for visualizing the left atrial appendage or the posterior heart valves, but it is a highly invasive procedure requiring conscious sedation and a probe down the esophagus. In an 80-year-old patient, the routine use of a T is simply not indicated. The clinical yield for finding an actionable source, meaning finding something like a patent Foreman oval that would actually change your management and require open heart surgery or intense anticoagulation in an octogenarian, is incredibly low. Unless you have a specific, roaring high clinical suspicion for infectious endocarditis or an intracardiac tumor like an atrial myxoma, a T is the wrong answer. A standard non-invasive transthoracic echo, or TTE, is perfectly sufficient.
Pitfall 2. Stenting the brain. We covered this during the atherosclerosis discussion, but it bears repeating emphatically because it is such a common error.
It is a huge trap. If the atherosclerotic plaque is in the neck, the extracranial internal carotid, you can safely operate or deploy a stent. But if the severe stenosis is greater than 70% in a delicate intracranial artery, like the basilar, the boards will aggressively tempt you with an angioplasty or stenting option. Do not select it. The Sampras trial definitively proved that pushing hardware into the delicate, tortuous intracranial circulation causes significantly more strokes than it prevents. The only correct answer is aggressive medical management, high-intensity statins, ironclad blood pressure control, and dual antiplatelet therapy for exactly 90 days.
Pitfall 3. Dropping the blood pressure.
This is physiological heresy in the acute stroke setting. If a patient comes into the emergency department with an acute ischemic stroke, they're outside the window for thrombolysis, and their blood pressure is screaming high at 210/110, you must do nothing. The board test makers know that every fiber of your primary care training is screaming at you to treat that hypertension. But the ischemic brain is desperately auto-regulating, cranking up the systemic pressure to force collateral blood flow into the dying penumbra. If you administer 5-labetalol and drop their blood pressure to a healthy 14/90, you will catastrophically eliminate the perfusion pressure to the penumbra, immediately converting a potentially reversible ischemic deficit into a permanent, massive infarction. You must tolerate the hypertension up to the absolute ceiling of 220/120.
Pitfall 4. Misusing oxygen. The patient arrives with an acute stroke and their oxygen saturation on room air is a perfectly healthy 96%. A well-meaning intern immediately puts them on 2 liters of oxygen via nasal cannula just to be safe.
This is a subtle but incredibly important physiological clue. The current guidelines explicitly state that you should avoid administering supplemental oxygen unless the patient's pulse oximetry is actually hypoxic, typically defined as 94% or lower. Supplying high concentrations of oxygen to a normoxic patient induces hyperoxia. This excess oxygen drives the massive production of reactive oxygen species and free radicals in the damaged tissue, which aggressively exacerbates reperfusion injury and cell death. Hyperoxia is actively associated with increased mortality in acute brain injury. Do not give oxygen unless they need it.
We're nearing the end of our comprehensive deep dive. Let's hit our rapid board review takeaways. We're going to alternate delivering 8 punchy, high-yield rules that you need to burn into your memory for exam day. I'll start us off.
If you see a patient present with a sudden, worst headache of life and their CT scan performed at 8 hours is completely normal, think immediately of performing a lumbar puncture to evaluate for xanthochromia to rule out a subarachnoid hemorrhage.
Number 2, if you see a lobar intracerebral hemorrhage located near the cortical surface in a non-hypertensive 70-year-old patient, think cerebral amyloid angiopathy. And remember to absolutely avoid long-term systemic anticoagulation.
Number 3, the next best step for a patient presenting with an acute ischemic stroke and a blood pressure of 19/110 who arrived perfectly within the 2-hour window is to first administer fevlabetalol to smoothly lower the blood pressure below 185/110 and only then administer the alteplase.
Number 4, avoid the temptation of ordering platelet transfusions for patients who suffer a spontaneous intracerebral hemorrhage while taking daily aspirin, as the data definitively shows it worsens their clinical outcomes.
Number 5, if you calculate an ABCD2 score of 4 or greater for a patient with a TIA, think immediately of initiating 21 to 90 days of short-term dual antiplatelet therapy to prevent an impending massive stroke.
Number 6, the next best step for a patient demonstrating an 80% symptomatic stenosis in the extracranial internal carotid artery within 14 days of their minor stroke is a surgical carotid endarterectomy.
Number 7, avoid the historic practice of initiating systemic anticoagulation, like a continuous heparin drip, in the first 48 hours of an acute ischemic stroke, even if they have active atrial fibrillation, due to the astronomical risk of causing a hemorrhagic conversion.
Number 8, if you see a patient experience a sudden, unexplained neurological worsening exactly 6 days after their subarachnoid hemorrhage aneurysm has been definitively secured, think delayed cerebral ischemia caused by vasospasm and immediately check a transcranial Doppler ultrasound.
We have covered an immense amount of complex physiological ground today. As we enter our closing segment, if you could boil this entire deep dive down into a single overriding concept for our listeners to take into the board exam, what would it be?
The single most important concept is the absolute, uncompromising necessity of distinguishing the underlying vascular mechanism. The board examiners will never let you get away with simply diagnosing a stroke and calling it a day. You have to ask the deeper question. Is it a large artery atherosclerotic plaque requiring urgent surgery? Is it a cardioembolic source from the atrium requiring a delayed DOAC? Is it small vessel lipohyalurosis requiring chronic blood pressure control? Or is it a fragile lobar hemorrhage from amyloid angiopathy where prescribing a blood thinner is essentially a death sentence? You have to diagnose the exact specific mechanical failure, the broken pipe, the clogged filter, the ruptured aneurysm, and apply the exact distinct evidence-based fix. That deep clinical reasoning is how you pass the exam, and more importantly, it is how you save the patient lying in front of you.
That is perfectly stated and brings the entire clinical picture into focus. Well, that brings us to the end of our comprehensive review. Thank you for joining us on Evidence at the Bedside Board Review Edition. Please remember to like this deep dive, subscribe to our show, and share it with your colleagues who are deep in the stress of board preparation. Until next time, keep the evidence at the bedside. But before you go, I want to leave you with a final provocative thought to mull over as you continue your studies. We spent a massive amount of time today dissecting the strict time-based clocks for interventions, the rigid 3-hour window, the 4.5-hour window, the 24-hour thrombectomy cutoff. But consider how the rapidly emerging use of advanced AI-driven perfusion imaging, which can calculate the exact ratio of dead ischemic core to viable salvageable penumbra down to the millimeter, might soon entirely replace this rigid time-based clock with a highly personalized tissue-based clock for all stroke interventions. The future of acute neurology might not care at all what time the clock says the stroke started. It might only care what viable brain tissue is actually land to save. Think about the profound implications of that shift.